Okay, so let's now talk about opening the consultation. So remember, in opening the consultation, what you're trying to do is set the tone of the remainder of the consultation so that the patient realises that they are going to be an active partner in this consultation. They're not just going to be passively answering some of your questions and you're going to make all the decisions. They're going to have to take some responsibility. And in this opening of the consultation, you're trying to build rapport so that they are going to be working with you to make a decision rather than you having to push against them, which is absolutely not the position you want to be in. And we know that first impressions make a huge difference. So if you can make the right first impression, that is an independent, significant predictor of whether or not the patient is going to be satisfied with the outcome. So it's hugely important what we do at the start of the consultation. And the way that we set a good impression is obviously how, what they see when we first meet them. So that's our facial expressions, it's our body language. Do we have it doesn't have to be a cheesy grin. If this isn't a happy consultation that we're going to have, if this isn't a positive sort of clinical situation, but we do need to have an open, sort of inviting facial expression and similar open body language. We're also, again, feeding into this, having this shared decision making. At the outset of the consultation, the chances are the patient might actually feel as though the greater power lies with the practitioner. And that's absolutely not the case, as we saw in the previous video. We need them to give us information. So this image of this power discrepancy is completely unfounded, but it's something we need to address. And the way we can address that is by introducing ourselves, by giving information, giving them our role as well. And by giving a role, that we're also not only managing the power discrepancy, we're also helping to align their expectations with what we can actually deliver. So for example, if they're entering into this consultation thinking, oh, well, actually, I should be seeing a doctor. I don't know why I'm seeing this prescribing pharmacist or this pharmacist. And by explaining what you can do, then you can immediately address any of those issues, those underlying issues. Conversely, if they think you can make sweeping changes across all their medication, across all their clinical conditions, if that's not within your remit, or if that's not within the remit of the timings that they have booked, for example, if you're primary care and they have a 10-minute consultation with you, then clearly you are not going to be addressed all of the issues that they may want to discuss. So by introducing yourself, giving your name and your role, you're managing their expectations. We also want to attend to the comfort of the patient, and this is that rapport building that we're achieving. These humanistic elements, things like if they're walking into your space, then they might be thinking, oh, there's 2-3 chairs here, where do I sit? And by saying, oh, look, there's, please feel free to take either of these seats, or point to whichever one, you're putting them at ease. If you're going into their space, so if you're ward-based, look at them. Is this the right time? Are they in pain? Is there something else that you need to deal with first? Do they have visitors around? And therefore, rather than awkwardly trying to stumble through the consultation, address that at the start. So you say, we are going to have a consultation now. Would you mind if they left? Or, establish exactly what involvement they will have in the consultation moving